Good morning, everyone, and welcome to the September version of our West Region Learning Community for Health Departments and some friends who are on the call. On behalf of all three of our capacity building assistance organizations, Denver, PTC, the California Prevention Training Center, and San Francisco, we welcome you today. As we've talked about over the past couple of months, our July through September quarterly theme is the diagnose pillar of ending the epidemic. And in that light, our final diagnose topic for this quarter is around HIV, HCV, STI, and more, may even be a little COVID in there, testing integration. And our facilitator today is the amazing Thomas Knoble, who is our San Francisco capacity building HIV testing in non-clinical settings lead. If you were interested in testing in clinical settings, you would go to the amazing Denver Prevention Training Center. And I am going to hand it over at this point to Thomas. Per our normal way of doing things in the learning community, Thomas is going to present about 10 or 15 minutes around some experiences from San Francisco, some lessons learned around integrated testing in the field to spark our conversation for today. And then, as always, we will have our guiding questions for you all to jump in on, which were sent out last week in advance of the meeting. So hopefully everyone had a chance to review those. We'll go through each of those three questions with our normal robust discussion from all of you, and then we'll have a little wrap up at the end, and we have a few updates on group site for you that the amazing Glenn Alexander from CAPTC will be sharing. So at this point, my privilege to turn it over to Thomas Knoble.
Thanks, Gary. So I work with, let me introduce myself quickly. So I've been working with the DPH for about 25 years now, and prior to that doing community work in the city and county of San Francisco. So a little bit of history with the PTC and partner services way back. And part of my primary role is working with community-based organizations who are doing HIV, Hep C, STD, and overdose work, and helping to liaison between those funded contracts and the health department. And what else do you need to know about me? I have a master's in social work in undergrad in Spanish and mixed race, Mexican-German mix, and gay man, and very dyslexic and a C student. So when I'm presenting, I always feel like I need to say that out loud just due to the fact that you actually literally may hear me say something backwards. Or sometimes my partner tells me that I admit words when I hit a certain cadence. So when you, you'll just notice that. So, and excited to be here. So what I wanted to do is basically on this next slide, Jesus. These are our three questions that we're going to discuss. So what I thought I would do is do a presentation on our experience of COVID in the last 15 months to kind of be a starting point or a jump off energy with regards to innovation and integration, and see if that kind of takes us into a space. I'd love to hear from others when we're done with regards to these particular questions. And if nothing else, just how did you integrate with COVID over the last 2 years? Because you'll hear our story, or at least my story with regards to what happened there. And I feel like it's a new day for public health and specifically for HIV, Hep C, STD, and overdose work. So we'll come back to these particular questions. Next slide, Jesus. So just want to talk a little bit about the history of what happened here, current, and then kind of our future state. So, and then a discussion. Next slide. So the past, next slide. I don't know why, I just love that picture of the city. So last March, this was our contact tracing team that we put together in the first couple of months with regards to case investigation and contact tracing. So I got activated early on, and this was the space that we were working at it. It's fascinating to me that we were all so close, and believe it or not, the masks were kind of newly introduced at some point in this process. And I'm just shocked that we did not get COVID as a little herd there, and I'll get it. We just generally got lucky. But what was happening is every person diagnosed with COVID was basically kind of envisioning going through this team. So we started to support thousands and thousands of San Franciscans in a moment of chaos and a point where they were in crisis, just due to the fact that we just didn't understand COVID, and the things that happened in this space were extremely intense. I feel like it was almost like if the only thing that I can really relate it to is a foxhole in World War I with regards to what happened here. So next slide. So early on, like this marker with regards to, I put that red arrow. This was basically our COVID cases happening. I thought that was a surge when we hit it. We were working 60-hour work weeks. We were completely exhausted. We were, as DSWs, we were spent and fried, thinking that any moment that it would, we would turn the corner. And you can kind of see from this graph that we hadn't even hit the peak yet with regards to what was happening for us. So next slide. The city basically started to, since we were completely overwhelmed, and at one point 50% of our new COVID cases were actually monolingual Spanish speaking folks due to the oppressions that are happening for that particular community, very densely housed individuals, and still needing to work due to the fact that that we would call folks and say, you need to stay home for 2 weeks, and they're like, yeah, that's not an option. So we really wanted to respond to the shelter in place and figure out what we could do. We had a network of about 25,000 tests that were being done with 16 different CBOs. And all of a sudden that work kind of ground to a halt. And so these community providers that we had working with our HIV, Hep C, STD work were culturally appropriate for the communities that were being impacted by COVID. And so we thought, how do we take this particular workforce and pivot it to help us with case investigation and contact tracing? Next slide. So this was my experience with regards to basically an HIV testing person does all of these things. And then I was noticing that case investigation and contact tracing folks are doing the things on the right. So basically giving somebody a result, providing emotional support, providing health education, providing resources. And I was like, you know what, these are both apples. They're not identical apples, but there's enough of a skill set that we can actually transfer that over to bolster up our contact tracing and case investigation efforts. So next slide. So this was just I mentioned this already, surge just started to happen. Like I remember going into work one day, it was prior to being even remote, and the concept of Zoom meetings and Teams and things along those lines, and just thinking, okay, I know what I'm walking into. There were 3 days where I knew exactly what I was going to walk into. And then that 4th day, like another one of these lines popped up, and we were just in complete chaos. And it was fascinating how every day there was something different, and it was an intense difference. So it wasn't just a minor change, but it was something relatively significant. Next slide. So we just had to change. We needed to figure out how to involve those community-based organization HIV testers, and we needed to do all of this work in order to make that happen. So we needed to, like, in a very short period of time, pivot so we can meet the community needs that were kind of, for the lack of, it was like a wave crashing over us. We just kind of had to accept that that's the spot that we were in, and pivot the health department like we'd never pivoted it before. Next slide. And part of that was basically doing trainings with these community-based organizations. And so part of what I learned from the HIV experience is keeping it mission-driven and making sure that we were connected. So we did a very kind of formal UCSF training with regards to contact tracing and case investigation. And then we augmented that with kind of a local perspective, a kind of an HIV training. And next slide. And these are just, you know, it kind of captures a little bit of the energy of how people were bonding and connecting with each other in a time where we were completely, we were just scared to go outside and connect with other people. And so we managed to find a space where people were able to do that in a time of crisis. Next slide. And at the same time, just to kind of put the context into it, we were building this program for basically nothing. We were having coworkers that were testing positive for COVID. We were working 60-hour work weeks. There was one particular client who the investigator reached out and said, you know, I'm looking for so-and-so. And she said, is this a joke? And she said, that's my mother. And she has just passed away 2 hours ago. And so the case investigator just basically stayed on the phone with her for a couple hours, kind of helping her process her grief. And what had happened is she lived in an SRO, and her mother had a cat. And at that time, they basically told her to abandon the cat because they weren't sure whether or not the cat could actually spread COVID to her. She went back and got it. And so, she called a couple days later, and I happened to pick up the phone, and she was just obsessed on the cat. And so it was a time when we just didn't have any information. I just said, go get the cat. Like, this is ridiculous. And she was grateful, but I always feel like the energy of that story kind of spoke to the chaos that was happening around us. So yeah, I personally lost my sister-in-law the day after Christmas to COVID. And so things kept kind of getting layered and layered on day by day. Someone in our community had committed suicide, and there were riots happening outside. And then this particular picture is from Moscone Center, which we ended up moving into. But this was noon. So I left the house in the morning and the sky was blue. And by the time noon happened, this is what the sky looked like. And so it was pretty surreal. And and then a staff member that I was working with was pregnant. And I remember just sitting there and having all these conversations. And I just turned to her and I said, wow, this really must be like, I can imagine I know how hard this is on me. Imagine being pregnant, not understanding how COVID might impact your unborn child. So, and these were just the things I could remember. So I remember going into work at one point and my brake on my bike broke. And then I was like, well, there's no time to fix that. Of course, 3 days later, the other brake on my bike broke. And I basically had to get to work 7 miles in San Francisco without any brakes on my bike. So one shoe was definitely worn down quite a bit when I arrived to work, but there was just no time to even take care of simple basics at that particular point. All right, next slide. So this is just the gang, kind of the first day that we showed up at the Moscone Center, which is our convention hall. And it was huge. It was a good workspace for us to kind of come together because we could socially distance and still make things happen. Next slide. So what we did is we provided these services, traditional case investigation, put this into place, and then started, we were able to train up 90 community-based staff to help us with the work that needed to be done. Next slide. So the current process, next slide. We have a complex network of UCSF staff, DSWs, 16 CBOs, testing sites, vaccinations, community organizations, the Latino Task Force and Recovery Group, all that we're now all very networked. We had community partners that were now new to us, we are now very intimately involved. And prior to COVID, we just didn't, the innovation that we had to go into these spaces really kind of forced us into a new spot. Next slide. These are a bunch of the community-based organizations. So next slide. And so what's happening basically is people are kind of saying that, like, let's not break down this network. Let's not break down this relationship with community-based organizations. Let's do Let's prepare for the next pandemic. And then I'm sitting there every time I hear that going, you know, we were basically invited into 50,000 San Franciscans homes, and we spent an hour and a half with them on the phone, and we got to understand some of the disparities that they're currently existing. So poverty, racism, Hep C, HIV, STD, all of these things are still happening. So when people say, let's prepare for the next pandemic, I'm like, there's a boatload of issues currently happening that we do not need to sit around and wait for something. And since we had such success with involving community and providing emotional and health education to over 50,000 San Franciscans, I'm like, why can't we do this for all these other disparities? So next slide. So currently within the city, there are over 6,000 community-based organizations. Obviously, not of them all relevant to health, but they're not connected. And prior to COVID, we actually could not share PHI with community-based organizations. And since we brought these community-based organizations into the fold of working with the health department on case investigation and contact tracing, the lawyers basically said, you know, we could share PHI with them. And so we're going to take advantage of that win and keep doing what we're doing. But instead of the triggering event being COVID, what the triggering event will be some other health disparity, unplanned pregnancy, HIV diagnosis, Hep C, recovery from overdose, or something along those lines. So if we can actually, next slide. So CBO staff are exhausted, turnover is high, the workforce is small at this particular point, and the training is also scattered all over the place. Next slide. We need to define what certain roles are within our community. Community health workers is the big title, but we're realizing that community health workers, promotores, outreach workers, and navigators are all very ambiguous, similar, but not clearly defined. And we want to take the opportunity to kind of pull all of that together while we have this network currently existing. Next slide. So our future state, I think there's only a couple more slides left. So next slide. So the top line is basically our experience with contact tracing and case investigation. The bottom line is basically the future that we want to move into with regards to using the system that we currently have in place for contact tracing and case investigation. So basically it's some kind of access point, some kind of triggering event, like I mentioned earlier. Somebody, a provider can now share that information with us. We can actually take that information, triage it to a community-based organization, and ask that community-based organization to actually actively reach out to that person and provide them that service, versus the current way, which is you're sick, you go to provider, they provide you a referral, and then it lies on the client to do the follow-up. And this basically is switching that at a point where everybody has cell phones these days. And so between us being able to share PHI and the fact that everybody has cell phones, we should be able to develop this network that addresses other health disparities built on the same structure that we have for case investigation and contact tracing. Next slide. I think I just said this one. So next slide. And then the benefits. So this is animated, but I think it's pretty clear. You can kind of click through it. Yeah, and there's just a lot of benefits for people having faster, easier access to services, a networked system. We pay a lot of community-based organizations to do outreach. And so now if we can actually have the outreach be flipped, they should be a lot more efficient at reaching new clients and not the traditional people that walk through their door or they currently have in their roster of people that they see. So we should be able to maximize the resources in the city in a whole new way. All right, discussion questions. So these are the discussion questions. Yeah, so I'd love to hear folks' thoughts or questions before we kind of move forward. And I have not been able to keep an eye on the chat. Sorry, Gary, I think I was supposed to do that. So hopefully I didn't miss anything.
Nope, no worries. You did not miss anything, Thomas. You're perfectly good.
Okay, cool. All righty. Questions, thoughts? Are we done? Nobody laughed. Okay.
I thought it was funny.
Thank you.
I was laughing. I was on mute. And if folks feel comfortable, this is a great time to turn on your cameras. We're going to be just doing some interactive chatting. Thanks, Thomas, for opening it up first to some general questions and thoughts about the San Francisco experience. I typed in the chat that I just love how this flips the traditional model on its head. You know, rather than asking the client, giving the client a card or a phone number or an email and asking them to navigate through all the realities in their lives to finally get to an organization, it puts the, you know, responsibility, just like with case investigation and contact tracing, on the organization. Like, we've given you this person's name and number, like, just call them and they're ready for the service with you because we already chatted with them. So I love that, and using that model to expand into this world. But would love to hear from others too about your thoughts. Bev says she loves it too.
This is Melissa Papp Green with Los Angeles County Department of Public Health. I'm relatively new to the HIV world, but one of the questions I had was, you mentioned that the lawyer said it was okay to share PHI, which I was like, like that was the biggest blown mind you said. But it's like one thing to say that you have a communicable disease that you got from getting someone breathing on you versus you know, being in a certain shared space, and another thing to say, you know, you got a certain disease from, you know, having you know, a certain behavior that is maybe not as accepted in our society. So my question is, are we now allowed to share, and again, I'm not as familiar with the HIV world, are we now allowed to share HIV diagnosis? We're starting an integrated HIV syphilis testing model in non-traditional settings. And we're in our assessment, our interview tools, I keep asking like the substance use counselors or the you know, program directors, I'm like, how many people are HIV positive? How many people have syphilis? And they're telling me, like, unless they disclose in an interview with us, once they're already in our program, we don't necessarily know. And when our test counselors used to go out, like in the old days, and test people for HIV, you know, they would interact directly with the client, and then it was the client's, you know, they had to go and get treated and everything. So you're right, this model has been flipped on its head, but how are we able to do this without, you know, disclosing HIV diagnosis? I mean, in LA County, our HIV data was like all the way at the top of our floor, like only 3 people could get in the elevator, like had access, like it was all crazy locked up. So how are you doing that?
Yeah, no, that's completely fair. And that definitely was, I mean, that HIV exceptionalism with regards to, I appreciate that there's an extra energy of wanting to protect the information, and at the same time, it kind of keeps a silo in place. And in some ways, it actually kind of keeps the stigma around that particular, you know, particular diseases due to the fact that that energy is there. So, I mean, all I did, to tell you the truth, was just with the COVID work, was just, I kept just asking the question. And what I've learned in the COVID experience is nobody has the answer. So if you keep ferreting out the direction, like you ask a question and someone bumps you to somebody else, and somebody bumps you to somebody else, and somebody bumps you to somebody else. And eventually I made it to the health officer, and the health officer was like, you know, we need to do this, so let's move on it. So yeah, I feel like it's a journey in yourself. You're gonna have to go back to your lawyers basically and folks and start asking the question. It's like, okay, what prohibits us? What's the barrier? And who can make the decision whether or not to move forward? And we basically kicked it to our city attorneys, and they were the ones that ended up giving us the green light. So, and with law, what I've definitely found is it's interpretation. So, and what we did is we made sure that we had a business agreement in place with the community-based organizations, and within that business agreement, it allowed us to share the information. So we do require that they do our the DPH HIPAA training. And so we make sure that we have that on file with regards to that they have that certification and that we have a record of that. And then that's going to need to be maintained annually. just like the rest of the DPH staff. But that feels like a relatively low thing to have to do with such a critical intervention.
I'm living on this discussion, not just as Thomas has done come to New Mexico and trained us in testing, but I keep looking at COVID as the year that destroyed public health. So what can we get out of it? And our win is not as big as having a community-based organizations do HIV STD partner services and disease investigation, because we hired contractors in New Mexico to do all the COVID stuff. So it was still theoretically under our umbrella. Like our big win, this is stupid, was electronic signatures on contracts and invoices, like all this stuff. But the parallel is, we had for years lawyers telling us that's not legal. And as soon as there was a necessity, suddenly it was legal, and suddenly it was the only option, right? And then we were debating electronic signatures versus wet scan signatures. But I think this is interesting because I'm a little more conservative about how I share data. I'm not sure I'd want our community-based organizations doing disease investigation and partner services. But there are a lot of other places where we do share data, and a lot of stuff is one directional. Surveillance reporting is to us. We're not sharing case level data out. But I think when the lawyers are willing to interact with you because it's a crisis, looking at those opportunities, that's exciting because and I also work in a department where half the time over the last 15 years, our cabinet secretary's been an attorney. We just have this weird tradition here. So sometimes that makes things harder. Sometimes it makes things easier.
Yeah. No, like our planning body as well. Like I kept pushing our planning body to meet virtually. And then all of a sudden COVID happened and nobody had an issue with it. I was just like, I pushed on that stone forever and a day. And now they're kind of fighting coming back in person. So that's another win that we definitely got with regards to the COVID fallout. And so.
Thomas, we have a great question from Cheryl in the Southern Nevada Health District. With the question of integrated testing, does this include offering HIV or STI testing at COVID testing or vax sites? Were we able to do that at all in San Francisco, or did anyone else in the West? Were you able to do that at all? But we'll go to Thomas first.
Yeah, no, we definitely were able to do it. It's just, and the Binex test is just so simple. It's fascinating. People were like, "Oh, this is hard," and I'm like, "It's easier than getting a urine or blood sample." And so it actually, I don't know how to describe it, but it actually brought down for me, the HIV and the Hep C rapid testing. We built up a lot of crap around it to make sure that community was doing it right, because they were taking on this role that's traditionally done in clinical settings. And then Binex came along, and it's like, buy it at Walgreens and you can basically do it on the bus on your way home or something. It was not hard. So it almost lowered the level of QA in a significant way for point of care testing for us. So, and we were able to integrate, again, anybody who was doing HIV or Hep C testing could do a Binex test really easy. The biggest part was actually doing the case investigation and contact tracing follow-up. And making sure that was reported to us. So, and since that was our realm, it was a relatively easy way to kind of bridge that gap due to the fact that we kind of had a foot in both worlds. So I'd love to hear from other folks if people were able to do involve the Binex testing. The Binex test, I don't know if anybody knows, but it has an expiration date. And then I've been doing HIV testing, and you have old test kits and use them for training and whatever you can, and you were always really regimented about those expiration dates. And now the Binex people are like, oh yeah, you can use them 9 months after expiration date or something, and that date keeps getting pushed out. And I'm like, yeah, they don't magically just stop working on October 20th or something along those lines. And I'm like, oh, now that's been validated by the fact that the expiration date is almost a suggestion date with the Binex product, because the state of California bought a lot of Binex, and so they didn't want that resource to go to waste.
And I saw Melissa shaking her head yes, and Jesus was chiming into the chat that LA was doing some HIV testing as well with their site. This might be a great time to jump over to the first discussion question, Thomas. So I'm going to hand that off to you so we can start getting a snapshot to see what's going on in the jurisdictions.
Sure. I would also too, just with the integration question, make sure the overdose. So one of our significant fallouts of COVID was the fact that our overdose rates they're just shitty. More people died of overdose in the city and county of San Francisco than died of COVID. And that part of that is just due to the fact that what we did is we took a lot of our hotels and sheltered people who were out on the streets. And so people who were normally around in a social setting, whether it be on the streets and would overdose, there could be somebody there that could reverse it, but then we put everybody in their own hotel rooms. And that isolation was a significant factor in people. And then I'm sure just the mental health of, the city was just, it was empty. It was weird. Like, it was depressing to go through it. And I can imagine people who were used to being out on the street, the psychological damage that kind of happened and the need for substances probably increased just due to that particular energy. So when we're talking about integration, I want to make sure that we have the overdose component in it, because we've been trying to engage people who inject drugs community, and they're just like, we've got this whole other issue going on. Like, your priority is not our priority. Great. So how are folks doing with integration?
And feel free to jump in verbally or respond in the chat, but it'd be great to hear around, which specific silos you're trying to break down currently.
Hi, this is Daniel from Humboldt County. And I guess with HIV integrated testing, as a county, we don't do that very well. We have one facility, which is a clinic, that pretty much does most of the HIV specialty, and everybody who becomes HIV positive is referred over to that clinic. This has made it to the point where a lot of providers, like general providers, don't really want to handle it. And a lot of the times it's also kind of tricky because we're also a rural community where there's a lot more conservative views regarding sex and just stigma still alive. And so because of that, people are just not wanting to test for HIV at all unless the person has like severe health that might be pointing towards HIV. And it's just been kind of like a huge barrier that we're kind of struggling with, is how do we convince the providers to do STI testing, HIV testing, and not just kind of push to somebody else to do it.
Daniel, do you know what that barrier is? Is it, so in our journey locally in San Francisco, what happened initially is when HIV hit, the clinical setting was just not comfortable talking about issues related to substance use or gay men's health or trans individuals. And so they just kind of acknowledged that they weren't culturally competent and said, why don't you go to these community-based organizations instead of me, because they can handle it better. They can take care of you better. And then so we actually had to spend years unprogramming that, just due to the fact that it's like, you have healthcare, you have insurance, it's your patient. You're kind of supposed to see them for these things. So while some of it was, it was just it wasn't quite conservative energy, but it was a self-awareness that they weren't the right fit. And I don't know if that helps at all.
It's really more on just the discomfort for providers in doing sexual risk assessments. It makes them really uncomfortable. One of the things is we are rural, so our population size for the entire county is 130,000. And so, whoever your patient is, a lot of them are people that you're going to know right around town. And we're also like a weird county because a lot of rural communities tend to run fully conservative or like a lot more conservative leaning. We're somewhere in the middle where we're very accepting of LGBT folks and things like that, very progressive on how they view weed, marijuana, but then there's just the talk of sex that nobody wants to do. And even in our emergency departments, when people come in with symptoms that might be related to STIs, it's pretty evident sometimes. The providers will still say, I don't do routine testing like HIV, syphilis, or Hep C. You're going to have to go to your local provider to do that. And then so many different barriers that also then starts to trigger, such as transportation issue. If people are also substance users, then they may not be the best at coming back in. And so, we're trying to prevent as many visits as we can, but the providers a lot of times just don't want to listen.
Thank you. Is there anybody on the call who's got any thoughts on that or similar experience, or are you kind of in a spot where people are not moving on something because of provider barrier?
I can speak to that for sure. I work for Wyoming Department of Health. I also previously worked for several years in a hospital lab setting, and a lot of ER providers that I worked with don't want to test for HIV or even syphilis. They just want to do chlamydia, gonorrhea, and send them on their way. They refer them to public health, they refer them to their providers. But like Daniel said, a lot of patients get lost to follow up that way. And I have a friend that's an ER physician's assistant. And I asked, why are you doing this? Why won't you test them? And they said that the only way that they'll test is if they are there with like signs and symptoms of HIV or have another, like AIDS defining illness, because they don't feel that they have the capacity to do it. And they want a counselor there if that person's positive. They don't want to have to cancel that patient on their results. Very disappointing.
Because if it's positive, they don't want to counsel them?
Yeah, they don't want to counsel them if they are positive. And I think that COVID has also compounded that because they are so busy, and especially in rural ERs, they have one provider and 2 nurses, and that's it for the entire ER. And they just don't feel that that's in their capacity.
Interesting.
I'll add on to that actually, just because that really resonates. A lot of the times it's true. It has a lot to also do with just the counseling bit. Our providers are so overworked because we lack access to healthcare, just because being smaller, being rural, there's not a lot of people who are trying to move to our county. And so, a lot of the times the providers just have way too many patients. And, we have some facilities out here that have not had new patients in like 6 to 8 years because of how challenging it is to get healthcare. And so a lot of the times when you suggest certain things, people will just say like, oh, well, I only have 20 minutes and they came in for heart issues, lung issues, and I just can't focus on STDs or anything, even though untreated STDs will require them to come back in for another visit and a whole slew of other problems because they're untreated.
And even like some of the providers I've worked with, there will be patients that are there for clear STI issues, and the only tests they get are chlamydia and gonorrhea. If they have risks for those, they have risks for all the others, and they are not willing to take that on.
Sexual health, yeah, kind of sexual health or drug user health, kind of we're trying to rebrand ourselves with regards to those are the buckets. And so if you're going to offer, like, this is what it means to when you offer that bucket, which is an HIV and Hep C testing. So I kind of ran into a similar energy once a few years back with our social workers at San Francisco General, where they were really, it was the counseling bit. They just were like, what, we do not want to go down that road. That's not our wheelhouse. We're going to feel too uncomfortable talking about anal sex or substance use. And I accidentally kind of stumbled into the solution to that by, we had a 2-hour training on basically to address this issue, and they were hardcore against being the one to deliver the HIV positive result. And what I asked them as part of the icebreaker question was, tell me your most difficult moment in the ER at San Francisco General. And it took an hour to to get through that icebreaker. But like one of the ones that really just traumatized me hearing it was this young couple had an infant child, and one of the parents had placed the baby on the ground behind the car, and then the other parent pulled the car out and ran over and killed the child. And so we went around this, we all had this like terrible trauma of everything that, imagine, it's 20 people and all of their stories. And then I turned to them and I said, and you can't give somebody a HIV diagnosis with a disease that is treatable and will actually have no, and that just clicked for them. They're like, yeah, we got this. So I don't know if that would help, maybe asking these providers that are resistant to, like, they don't want to, if it's timing, that's one thing, right? But at the same time, it's like, have you done something more complex in your role as a provider, and seeing what that answer is, and then saying, oh, compared to what you just told me, telling somebody that they've got HIV is within your wheelhouse. So it was an odd way of empowering them, but it was extremely effective.
So Thomas, this is Ty. I think that makes a lot of sense in certain circumstances. I do think, so there are several issues being collapsed into one. I think a lot of times people don't have the skills to do an affirming sexual history. So that ups their anxiety around this issue of providing a diagnosis or entering into the counseling space. Two, I think we've talked about the issue of time, but then I think in some low resource areas, some of the providers are doing too many things and it's just a little bit overwhelming. So I think that we do need to think about, yes, what does provider burnout look like? But I also think that there are several other ways that we can think about how to equip people with the deficits in the skills that amp up the anxiety around some of those issues.
I know also for like our county, one of the challenges that we have with providers is even just getting them to attend educational, like conferences and things like that is really, really challenging. Many of them, we will send emails and emails and emails and sometimes calls, and many of them still will not show up. And so, as much as we want to believe like educating is a great thing, if they're not even willing to show up for the education, there's not a whole lot that we can really do. And that's kind of what we're trying to figure out. Yeah.
Made me think about, I'm sorry, just real quick, and based on what Daniel announced and what also Ty was saying, and even when I'm reading in the chat box, I'm not sure, just thinking about various like community health worker models, especially I see they're being used a lot in various parts of in Africa, and they've been quite successful. And I think it's been a great way to show like the partnership between community and providers, and how into like, and best to respond, right, to various outbreaks or what have you. And I'm not sure if like, what would that look like for us when we're thinking about the overwhelmness of providers, when we're thinking about even our innovative strategies that we're doing in communities, and even the restrictions that are placed right now on CBOs based upon COVID. What would that look like? And looking at some of those best practices and seeing how do we maybe modify, tweak what we're currently doing, and using that to find ways to operate in this more collective matter, where we're looking at all of the talents, even the current issues or concerns that we have in our respective fields, but how would we use that to bring that together for this comprehensive plan that allows us to tackle this, and also allows us to have the support we need as providers in this, and community folks. But that's a whole lot, but yeah.
Yeah, no, I agree. It is a whole lot. And then I also do struggle with like, okay, if I'm treating this provider as my client, like, and I'm hearing what they're saying with regards to priorities, that's part of the journey. It's just like, okay, I'm hearing that you have other priorities when you have a certain amount of time with the person. And sometimes, you're just not going to win that battle, just due to the fact that there's other things competing during that exam.
So Thomas, there was a comment earlier about, providers not wanting to do counseling with patients. And maybe this is a California thing only, and different state laws or expectations are different. But I thought that is counseling mandated in some states still? I know in California, we can just do testing without necessarily counseling the patient or having that session. I know CDC was trying to get folks to move away from that model. Is counseling still required in some places, and other folks just opening that up to everyone on the call? Or do you mean counseling if the patient's tests happen to be positive, like the having to manage that afterwards?
I think that was my comment. I think the providers are just really struggling with like having to manage that patient after they receive those news,
Gotcha.
and they have all these other patients they need to see. And I think they don't want to deal with the time that takes because they're the only ones there and they have other patients, or they have an ER full of COVID people, or XYZ different options. And I don't know, Leslie and I were talking if maybe we did some education that most of the HIV diagnoses in our state are late, if maybe they would be more willing to test early, but I just don't really see that changing much for them.
Hey, Caitlin, it's Leslie. I mean, part of it is that in Wyoming, it's already a conversation related to sexual health that, there's so much stigma. People already don't want to have that conversation. And so if you can find a way to say, I'm not going to do this because I have other things to do, I think it's easy to say that. I mean, legitimately, they have other things to do. And the provider to population ratio is terrible here. There's not enough providers.
Yeah.
And I get that, and I empathize with that. Also, if we had a higher incidence, they'd be more inclined to test. But if they test, then that would prevent us from having a higher incidence. So what are you supposed to do? It's hard to convince them.
Yeah, I think your comment about the stigma is so accurate, because if I went into the ER for something, like I have this really high raging fever, and it's been days and, not sure what to do. But I was also sitting there with a broken arm, like with a bone sticking out, be like, oh, by the way, I think there's this thing going on as well. They wouldn't just go like, well, no, you just came in here for a fever. We can't do anything about that arm. And so I think you're right about, that the stigma piece is so strong, in that. And it's, in a way, it's an issue that's, because of the stigma, it's an issue that can be like avoided, by people, whereas something physical can't. Ty, you're raising your hand.
Yeah, so I agree that there is that stigma piece there, but I also think that stigma piece is buttressed by people feeling that they don't have the skills to adequately respond if things go up. So I think as there is a skills deficit, it does increase a lot of people's anxiety to jump into that space. So not only do we need to develop something to help people deal with stigma, which is what we all have stigma courses, but there is this desire to build people's skills to deal with some of those issues as well.
Yeah, and to Cheryl's comment, I think that's where detailing can be a great strategy, because it allows you to sit one-on-one with the provider and explore a little bit, focus on the skill piece. And, once the provider, if there is, a skill need there, you're able to help start addressing that. But if there is a stigma issue as well, you can potentially, start having a conversation about that at the same time.
I also do. I appreciated the comment around just educating people that most of the people who are being diagnosed are late testers. And in the partner services days, a lot of providers were highly motivated about stereotype, but just women and children acquiring HIV are often getting it from a male partner who goes undiagnosed for a long period of time. And so the way that you prevent that from happening is you test people earlier. So if the motivation of protecting women and children is something that the provider might respond to, just generally kind of sharing the story. It's like, you know what, I had a client who her husband or spouse ended up, having HIV. It was undiagnosed for years. And now her child and her are living with HIV just due to the fact that a provider did not have the opportunity to intervene sooner. So it's a nuanced conversation, and it's not necessarily like you need to do this, but that might be a way to provoke them to or tap into a motivation of theirs that might help them introduce that screening. And I think what Gary was trying to say was kind of decoupling the concept of counseling from an HIV test and just making it, or even STD screening. It's like, you just have to check a few boxes and to say, hey, I'm going to run an HIV, Hep C, STD test. It's what we do for everybody these days. I think if anything, maybe they just get a little bit nervous that somebody will be like, how do you get HIV? And then they're going to find themselves in that moment of like having to do it. Then they need the skills, which I was just hearing were really relevant. So it's a good discussion. I appreciate it. Please, Melissa.
I had a question, Caitlin. Are you guys dealing with, and I'm sorry, I'm not familiar with your program. Are you guys dealing with substance use and meth and opioids?
Yes, that is a definitely mostly meth, I would say here, some opioid. We are also in a tough state because our laws do not allow for any like SSPs or medication assisted treatment, anything like that. And Leslie can speak to more of that, but so it's really hard in this state to support people who use drugs because it's not a thing here.
Well, one of the things that I was going to couple off of to what Thomas said is the way that you can kind of, and the women and children part that does motivate people, especially people of certain faiths. And again, I'm not condoning this behavior. I'm just acknowledging that this is how things are. You might want to like talk about the folks down in Los Angeles who are seeing, had 4 cases of perinatal HIV transmission, and the 3 moms all of them had STDs. 3 of them had syphilis, 1 had gonorrhea, 3 of them were homeless, but 1 of them was from a partner who'd been incarcerated. So incorporating more universal screening into everything, because you can, and because people won't disclose their drug use, I think we really need to move more towards universal screening for all of these things. And in Los Angeles County, I was trying to figure it out. I'm not in my office. So we passed something where if you go to an ED, an emergency room department, like you have to get tested for certain communicable diseases. I can't remember if that was just an LA County thing or if it was a state thing. I apologize. I usually look at the letter up on my cube, but maybe that's something that you guys want to work with your state legislature or your county office of health, or your health office or whatever, to try and get that in there so that it becomes universal and standard of care, and that it becomes just a blanket thing that they're used to doing. It goes into their workflow, goes into their order set, and then, and you see what you find.
I wish that would be a thing here. I just don't know. Leslie, do you want to speak to that? Yeah, it's hard here.
There's lots of things. And one of the things that I've spoken at several conferences on, like issues in frontier populations, and what's evidence-based and what's palatable to the population and the legislatures are 2 very different things. And even though we know that, it's something we always work on anyway. We can't even get a statewide LGBTQ rights thing passed, a law passed here. So I think that getting, required HIV testing and ERs would be a tall order. And so, we just start with our champions and take our baby steps and work our way up. It's going to be many years, but, that's where we start from. We do have people that are using drugs and injection drugs. It's not out in the open like it is in some cities. And our biggest city is 50,000 people. Our state population is 500,000. I mean, we do have medication assisted treatment, but it's very sparse, and our state is sparsely populated and rugged, and often it's more than a 2-hour driving time to get to a location. So these are things we do take TA on and do the best that we can.
Right, because the culture of those frontier states is very different. And it's a big thing for us to consider here in the West.
Cheryl?
Yeah, I was just going to say that I know this legislative session, I mentioned that we had quite a few bills that passed about trying to change some of this, you know what I mean, approaches to getting more information about like Senate Bill 211 basically has providers, primary care providers and ED or emergency departments ask if people would like an HIV and STI testing. We also changed some of our laws on congenital because we're unfortunately pretty high, as many places are. And we've had a lot of like HIV modernization also was passed this legislative session, but I think that's part of one step. What we're kind of still seeing now is that it's one thing to pass the law, but then the other is we still have to educate the providers because they're not getting it yet, you know? And I think I gave an example. We just did an academic detailing session to providers, and I was kind of amazed, like they didn't really, it was on PEP and PrEP, but a lot of knowledge was not there. And even talking about sexuality, you could see almost this like, so it's like you know what I mean? I think we start these big initiatives, but it has to keep going through with education and kind of continuing these very integrated models. And I believe a lot of our providers, like we do have SSPs here, so they can do HIV and Hep C testing and others. So we're trying, but I still think there's a lot of work to do.
For sure. It's funny, people will say stuff to me, it's like, oh, that's a lot. I'm like, really? There's so many, it's like a lot of stuff on the books, and do people actually follow it? But it's great to have it on the books. It's great to have that support behind you. So that's definitely step one.
I think that's part of it too, though. It's just a matter of like things may be part of the law or part of policies, but a lot of the times if these providers are not being reprimanded for it, it's kind of all bark, no bite, because then it's just like, well, you can tell me what to do, but I'm just not going to do it. What we can do about it. And I think that's one of the big things that we're seeing is just because, again, being rural, you don't have a lot of people coming out here. And so a lot of the times providers can go about and doing their thing, and there's not a lot of things that we can do about it as punishment, because what's the alternative? We lose our providers and we don't have any providers at all. Like even dentistry out here is a challenge. Like we have kids with rotting teeth because getting a dental appointment is next to impossible. And so, it's a lot of things that are just harder when it comes to rural communities compared to like city communities where there's a lot of just opportunities and people who are there that can always take the place of another. It's a lot of politics out here that I'm finding is an issue.
Definitely. Feel like the champions component of trying to find just that one person who will locally make stuff happen, and then just building on that is usually the way that we've been successful in the past. But my work with New Mexico, like that, they introduced me to the term frontier. I didn't realize it was a technical term. Like it's a technical term where the population is so dense that it's not rural, it's frontier land.
That's like 5 or 6, depending on which resource you look at, per square mile. And in Wyoming, 17 of our 23 counties are classified as frontier.
Wow. All right, that just blew my mind. The other thing too, just like we kind of went through a similar process with regards to Hep C treatment. That was like kind of our latest, where a lot of providers were just not willing to do Hep C treatment. And then as the new treatments rolled out, we just started finding more and more providers. We took a few that were willing to do Hep C treatment. And we're actually now even programming where we can do Hep C treatment and syringe programs. So people are always like, oh, the client will not show up to the clinic. And I'm like, well, they'll show up to the syringe site every day. So why don't we move the services there? And so that's still in its kind of infantile state, but it's obviously kind of a cultural fit for that particular population, and seems to be really successful. So, but there's always there's changes. It just takes time. So for sure. All right. So any other strategies or thoughts or?
Anything that's actually working really well in terms of integration, you can always share in the chat as well.
I do feel like part of the, if just using the CEBA network as a whole, when hitting these issues, I always feel like bringing somebody in from someplace else, even if it is from, you know, city to rural, sometimes it dislodges something. To have the, you know, crazy guy from San Francisco come and talk about how rich and wealthy they all are and how easy and politically forward it is. Sometimes people are like, okay, that landed, and something will move. But I always feel like I'm willing to take that risk, just go have those hard conversations with leadership in some other county, and see if we did some really great work not too long ago, just before COVID, with Oregon and some of their harm reduction efforts. And I was really inspired by how those harm reduction folks were actually moving the needle with very little resource in very conservative areas. And, you know, people were picketing their syringe sites. I was just like, really, you don't have anything better to do than like harass people who are actually picking up clean works? And that was the reality. And they were out there countering that energy and showing up for clients every day, even though it was like a personal threat to them. So I'm not sure where I was going with that, other than the fact that it was just inspiring. All right. Anything else?
One of the strategies that I'm going to be suggesting to our local clinic, you know, they have 11 locations and they're probably one of the most widespread facilities in our county. I'm going to hopefully suggest a meeting with a quality improvement person. The only reason why I didn't bring it up is it's technically not successful yet. I'm hoping it will be. It's just, you know, if the providers don't want to do the sexual risk assessments, I'm hoping that the nurses or medical assistants, you know, they can just kind of, we can automate it and just see that, like, you know, this person hasn't had an STD test in a while, they have an alert through Epic or something. And then, you know, the RN can just be like, we haven't had one in a while, we're just gonna give you one if you don't object to it, type of thing. And then the provider just has to kind of check it off. That way the provider doesn't have to do much, doesn't disrupt their workflow. And it's as simple as just recognizing that you should be tested for an STI regularly. That's like best way that I think of circumventing providers not wanting to do the sexual risk assessment to begin with.
That sounds like a great idea. Please, Beth.
No, I was just gonna say, Daniel, I ditto that idea, and we've done that in our HIV clinic many years ago, you know, as everyone was getting busier and we had medical assistants and just other folks working in across our team. We just started to use people. And again, this is encouraged by insurances and our federal kind of clinical governing bodies like IHI and all that, you know, using people to the top of their scope. So actually making it a built-in order, and the blood is drawn or the vaccine is given without a provider having to engage with that, and letting the providers do, you know, what's at the top of their scope, which is diagnosing and treating. So that's a great idea around integration, because it makes it seamless. And again, it's all about not adding to people's plate of things they have to do, but actually making it more efficient. And I know for a fact, all clinicians love that.
Thank you.
I'm so glad to hear that worked. I'm excited then.
Thank you. We have a few more things to accomplish on the call today, so don't sign off yet. But I wanted to thank Thomas for his sharing of the San Francisco experience and facilitating our discussion. Air snaps for Thomas, if you're on camera, thank you. So a couple of things that are critical to all of you right now. First is, Jesus just popped the evaluation link into the chat box. Please click on that. You can start working on it, but you will not be able to access it once we leave the meeting. So you definitely want to at least open that window now so you have that. And in a moment, Jesus is going to share on screen the gowest.groupsite.com. And we have a few new things to share with you on that. So the first is we have started, if you look on the left-hand side navigation, you'll see that there's an option called blog. We don't really blog on our West Region group site, but what we decided to use that feature for is to, for a record of all of these learning community sessions that are held. So whether that's the health department one or public health detailing or the previous EHE ones or whatever it might be, they're going to be saved in the blog. And Jesus, if you can scroll down a little bit, there'll be a similar format each month. There'll be a link to the recording of the session, as well as a copy of the slides and any other materials that were shared. And then there will be a brief summary of the meeting notes as well, usually based on our guiding questions. This is a helpful reminder. We don't capture anything personal, but what we do, if you scroll down a little bit, Jesus, is we share a little bit about kind of what each jurisdiction said in response to some of the questions. So who are you focusing on as a priority population? What's your biggest challenge? What's your current success? Things like that, so that for those of you that were on the call or for those that missed it, can see some of that, some of the great suggestions that folks made on the calls are on there as well. This is really to help capture those thoughts. So a week from now, when you go back and say, I know someone shared some great stuff about what they were doing in a jurisdiction, but I can't remember their name or their state, you can go back to these and can help you reach out to those folks in the learning community. And then I'm going to turn it over to Glenn, because we also have another new feature that's going to be starting today in the discussion forum. Oh, we can keep the group site up, Jesus, sorry. And if we can just go to
yeah, sounds good.
Homepage.
Thanks so much, Gary. Yeah, so while that's popping up, hello everyone, I'm Glenn Alexander. I'm part of the SEBA team. And what we're going to be doing following this discussion is we're going to continue the discussion. So Thomas, during the slide presentation, offered up a couple of phrases to get us started, and the conversation was really, really good. So we're going to continue that on group site. So if you're looking at the screen now, you see off to the left where it says subgroups. We're going to be inviting you into the subgroup for this particular group. And the questions that we started, which is the CDC funded health department subgroup, we're going to post those questions that we were engaged in on this call on group site to keep the conversation going. So following this call, I will post those questions to this subgroup. If you are not part of the subgroup, we're inviting you to join the subgroup. If you are not a member of group site yet, you're not familiar with it, I'm going to put my email address and contact in the chat box. If you would be so kind as to send me an email directly if you're having any issues logging into group site, accessing the subgroup, anything of that nature, so that we can get you connected and then we can really get some two-way dialogue going. This is a great platform for a two-way conversation, and this was a great discussion today. So we'll continue this same discussion online, and I will be posting that preceding this meeting. And Gary, I'll turn it back to you.
Great. Thank you so much, Glenn, for helping to continue the conversation after the call, because we know there are definitely folks in the community who weren't able to attend today, and that's such a great opportunity to keep sharing challenges and successes. So thanks everyone for joining. Just to give you a preview of what's happening in our next quarter of calls from October to December, our pillar framework for the next 3 months will be the prevent pillar. So we're going to be talking all things PrEP, other biomedical prevention strategies, and things under the prevent pillar. So look forward to those discussions. It's going to be an exciting 3 months. And look out for some emails announcing what those specific topics and other things are going to be. And this is your learning community. So if there is a particular topic that you think the group should be focusing on because it's critical in the field, there's something coming up, there are new changes, there's new science, etc., please let any of the 3 SIBA providers know. And Ty Edward Few is the manager at Denver. Anshe Hall Everett is the manager at CAPTC, and I'm the manager in San Francisco. But you can reach out to any of our staff that you have connection with, and feel free to suggest topics. Also, if you know folks who would be great to have at the beginning of our call to talk about something innovative, to the frontier conversation earlier, we don't always want to have, the experiences coming from similar communities and jurisdictions. Maybe there is someone out there in a frontier county that is trying something innovative and something new that is gaining some traction. We'd love to have them as our facilitator and talking about some of their experience so that we can have that lens in our work as well, because we all have frontier portions of our states. So thank you all for joining. Thank you all for clicking on the evaluation before you exit. Just scroll up a little bit and you can see that. And you can always go to the group site at any time by going to gowest.groupsite.com. If you haven't joined, you can click and request to join, and we'll approve you right away and get you into all the relevant subgroups and other things that are going on. So thank you all for a phenomenally interactive session today. And one final thing, a number of you put in TA requests in your jurisdictional SIBA plans around integrated testing. One of the things we're piloting since our August call on SNS is following up with those jurisdictions who had the topic of the learning community call also as a TA request in their jurisdictional plans. So those of you who put in some type of TA request around integrated testing, will be reaching out to you. Probably the lovely and amazing Thomas Knoble himself will be reaching out to you to check in to see if that might be a TA request you're ready to work on, or whether you want to do that a little bit later when some things change in your jurisdiction. Timing is totally up to you. What we've also looked at is the potential of doing some group TA so folks have the chance to work together. So exciting opportunities. That's a new thing we're trying with the learning communities, is to follow up on these TA requests after these calls. And you'll let us know whether you're ready to work on that issue or not. If you didn't have integrated testing in your jurisdictional SIBA plan, that's okay. You can totally add it at any time that you want. And if you're a jurisdiction who never got to create a jurisdictional SIBA plan because you're not funded by CDC, you can still request TA on integrated testing, both clinical or non-clinical settings. And all you have to do is talk to your state CTS coordinator, and they can get a request submitted for you that will come to Ty if it's clinical HIV testing, and to Thomas if it's non-clinical HIV testing. So anyone who has a need right now, we're either following up with you, or you can request it, or you can reach out to us directly. So look forward to doing that work with you all as we move forward. And thanks again, everyone, for a phenomenal session today. Bye, everyone.
Take care, everybody. Thank you.
And don't forget to click that eval link before you leave.
How many times should I fill it out, Gary?
The eval? As many times as to make you look great.
There you go.
Awesome. Thanks, everyone. We'll give last few folks a chance to click on the link before we leave.